Teacher, sir, you can start.
Shall we start, sir?
Yes, you can start.
Think.
It's already 8:01.
Yeah. Dr. Shaji, sir, are you there? Hello, Dr. Shaji, sir. So, good evening, everyone. So, on behalf of the IBOMS case series, right, I am welcoming you all for this session. I am going for the introduction of Dr. Vidyarathan, sir. He is the moderator of the today's session, and it gives me immense pleasure to invite today's moderator, Dr. Vidyarathan, sir, for the IBOMS case series 8 on TMJ ankylosis. So Vidyarathan, sir, as that is BDS from Government Dental College, Patiala in 1989, and he completed his MDS from Nair Dental College Hospital, Mumbai in 1993. And he is currently the professor of OMFS at Postgraduate Institute of Medical Sciences, Medical Education Research, Chandigarh. He has more than 100 publications in national and international journals for his studies. He started the postgraduate teaching program in OMFS at PGI Chandigarh. He innovated a new technique of transposing buccal fat pad into TMJ region, which has reduced the chance of re-ankylosis. He is the reviewer of the prestigious International Journal of Oral and Maxillofacial Surgery. His areas of interest are orthognathic surgery, temporomandibular joint surgery, and maxillofacial trauma. And now I request Dr. Raviraj Kumar to introduce the panelists. Over to you, Raviraj.
Thank you, Kishore sir. We have three panelists today. Our first panelist is Dr. Ajay Rao Chaudhary, Dr. Om Prakash, and Dr. Mukul Padye. Coming to our first panelist for today's webinar, Dr. Ajay Rao Chaudhary is one of the senior faculty of our association. He is presently the professor and head, Division of OMFS, Center for Dental Research, All India Institute of Medical Sciences, New Delhi. I welcome you, sir, Ajay Rao Chaudhary, sir. Thanks for spending your valuable time. Dr. Om Prakash from RIMS Ranchi is our second panelist today. After his MDS, he cleared DNB exam in the year 2005, FIBOMS in 2012, CCGGM in 2020, and MNAMS in the year 2021. He chaired many scientific sessions at state, national, and international levels and delivered guest lectures and keynote lectures at many events. He has around 18 publications to his credit at various national and international journals. I welcome you, Sir Om Prakash, sir. And last but not the least, my very good friend and my mentor, I can say most of the time I keep getting kicked after talking to him most of the situations. Dr. Mukul N. Padye is presently working as a Dean of Faculty at D.Y. Patil University, Navi Mumbai. Previously, he is a professor and head at the same place of Division of Oral and Maxillofacial Surgery. He served as a president of AOMSA Maharashtra State Chapter from the year 2017 to 18, EC member of our national body 2 terms, 2016-17 and 17 and 18. He also served as a joint secretary of AOMSA for the year 2018 to 19. He is a private practitioner since 26 years in Navi Mumbai and Thane, and a consultant at Sir Hiralal Nanda Reliance Foundation Hospital, Mumbai. Welcome, Mukul sir. May I now request the moderator to start the session and enlighten the audience.
Good evening, everyone, and welcome to this webinar. So, this is the format of webinar. First, I will be introducing the subject. Then we have 3 cases for discussion. Once I introduce the subject and what are my thoughts on management of temporomandibular joint ankylosis. After that, we will have 3 cases for discussion in which we will be involving each panelist and taking views so that you can learn how to manage and treat ankylosis cases. So slide is visible. Everyone can see my slides.
Yes, sir.
Okay. Ready to go. So temporomandibular joint ankylosis, as you all know, is an inability to open the mouth. And it can present in various forms with various clinical manifestations, depending on when trauma occurred, when the infection occurred. If it occurred during childhood, then it will lead to gross developmental abnormalities, whether it is affecting unilaterally, it is affecting bilaterally. You will see various forms of investigation. And if patient reports late and there is no intervention done, then gross deformity of the face, which is challenging to treat. And when it is of late onset, growth has already occurred, then you will not see any deformity on the face. So how does it occur? Basically, in our country, we see traumatic. Most of the cases are traumatic. Around 90% of cases, it occurs following trauma. And some cases do occur after infection. Basically, there is hemarthrosis following trauma, and that lead to new bone formation. And infection lead to fibrocartilage desorption, that lead to new bone formation, which leads to ankylosis of the joint. Trauma basically occurs to the chin during childhood, and there is sagittal fracture of the condyle, leading to displacement of the condyles laterally. And these condyles get stuck there. As you see in this, there is sagittal fracture, and this lateral portion is stuck with the zygomatic arch, which will fuse, and medially, this condyle is preserved, and there is meniscus. So that meniscus prevents fusion of this joint on the medial side in traumatic cases. But when it is infection, you will see uniform fusion. For example, this is traumatic ankylosis. There is lateral fusion, and on the medial side, there is preservation of the condyle, which is not fused. And recently, in May, this Feb, in IBOMS, we published our series on differences in morphology of temporomandibular joint ankylosis of traumatic and infective origin. And in this, we studied 30 joints of traumatic origin and around 15 joints of infective origin. And in all the joints of traumatic origin, this was the picture. On medial side, there was this condyle, maybe rudimentary, but this was well preserved. And in infection, as in the central portion, you see there is fusion in the joint, which is not going out of the joint, but there is uniform fusion throughout. So to manage ankylosis, these are the treatment goals. You have to achieve mouth opening, which is normal, pain-free, and patient is able to have normal oral functions. Then re-ankylosis is a major problem. Once you operate, then there are high chances of re-ankylosis. So prevention of the re-ankylosis is major goal, so that whatever you have done doesn't go waste. Then you have to correct various facial deformities. And when it is involving the mandible is microgenia, hypoplastic, that leads to obstructive sleep apnea. And all this you have to achieve these goals with reasonable cost of treatment, because majority of the patients are poor, come from low social background. So cost is another factor which you have to consider while planning for the treatment. So there are various surgical techniques. Gap arthroplasty is the initial treatment which was done, but there are high chances of re-ankylosis. So to prevent re-ankylosis, some interpositional materials have been tried, and then some people do subankylotic osteotomy. When there is extensive ankylosis involving base of the skull, which when you try to remove can be life-threatening. For example, in sub-Saharan Africa, following NOMA, you see extensive fusion of the joint involving maxilla, coronoid process, and sometimes in syngrathia type fusion also you see, which is developmental, massive fusions. Those are challenging to treat involving base of skull. So you try to do subankylotic osteotomy in those cases. There are various surgical techniques to reconstruct the ramus condyle unit, which have been tried, maybe autogenous. Then distraction has also been tried to reconstruct ramus condyle unit, and recently total joint construction with alloplastic or stock joints is also coming in vogue. Earlier, alloplastic materials like acrylic or elastics, they have led to poor results. Most of the times there will be extensive fusion around those materials, and then you have difficult time taking it out. Temporalis muscle flap is an excellent interpositional material which is locally available, and it helps in reducing the chances of re-ankylosis. And everyone knows about Kaban's protocol, but Kaban's protocol is not based on evidence. He just, based on 10 or 12 cases, he published his protocol, which I am not in agreement with, because this disease is our disease. We have to make our protocols. Kaban suggests aggressive resection of bony mass through extended hemicoronal approaches. He is making a huge gap. And then he is trying to reconstruct that with either costochondral graft, or recently he has said transport distraction. These are from his article. With transport distraction, he is taking that condylus trunk up and trying to reconstruct that huge gap. But what I think, such a large gap is not required. You have to remove the ankylosis in toto completely, but not to prevent ankylosis. Large gap is not required. There are methods where you can prevent re-ankylosis. For example, this is a case where there is fusion, and we have removed this total fusion and just created this around 5 millimeter of gap. There is no heterotopic bone, just we have released the fusion, and then there is no need to reconstruct this. For example, when you are doing high condylar shaving type of procedures, you remove around 4 to 6 mm of bone, but you never think of reconstruction. But when you are treating ankylosis, you always think of reconstruction with either alloplastic or autogenous materials. Another traumatic case where there is lateral fusion, just to remove this laterally ankylosed mass and medially this beautiful condyle, which is covered with meniscus, which is attached to lateral pterygoid muscle. This will function, this will grow for whole of the life of the patient. Another case with bilateral ankylosis, medially, you see these condyles are not fused. Just to remove this laterally placed fusion, and you see you can preserve medially, and these condyles will function normally. Another case, just lateral fusion, and What I do, I put fat here to prevent re-ankylosis. What is being suggested? Create wide gaps to prevent re-ankylosis. Reconstruct that with alloplastic or autogenous material and then place fat to prevent re-ankylosis. That doesn't sound any logic to me. Just there is fusion. You have removed that fusion to prevent re-ankylosis. Put some material so that there is no bone formation again, and these joints will work beautifully for these patients. And re-ankylosis is major challenge. This girl has been operated 3 or 4 times, still she can't open mouth. Every time you operate, more raw area, extensive bone formation, and earlier costochondral grafting has been done, but still she can't open. Costochondral graft had fused. So prevention of re-ankylosis is a major challenge, and for that, fat is being favored now. I'll suggest whatever you do, whenever you operate any joint, put fat to prevent re-ankylosis. Because whenever you operate, there is osteogenic milieu in that joint. There is tendency for bone formation, and that when you pack it with fat, it converts osteogenic potential to adipogenic potential, and it prevents new osteogenesis and fibrogenesis. So in 2006, I had published this. After that, I have done hundreds of cases with this technique, and it has always worked. So rationale for placing fat around the joint is to obliterate basically dead space. Because being semi-fluid, it goes everywhere into nooks and corners. It prevents hematoma formation and its subsequent organization, and adipogenesis inhibits formation of bone and cartilage. So it minimizes the chances of re-ankylosis. And it is lying there in the same area, just you go anterior to the coronoid and you can pull it into the same area without resorting to any second surgery site. And we have extensively studied this. Long term, it is there. After 1 year, around 60 to 67% fat we could see after 1 year. It was there on MRI study. These are the MRI after 1 year. You see fat is still lying where you have placed. And then next, jaw physiotherapy. Once you have released, that is very important. Patient has to continue jaw therapy for at least 6 to 8 months. And there are various devices. This is which I use as Hister's jaw opener. But when patients have primary dentition, then this Hister's jaw opener cannot be used because it damages the teeth and patient gets pain, and this Therabite or Orabite appliance is recommended when patient has primary dentition. So we have analyzed our cases, and these cases treated with this technique can generate bite forces equivalent to around 80 to 90% of the normal patients. We compared it with normal age matched group. These patients are functioning well, mouth opening is good there, and then quality of life. We assess these quality of life had tremendous improvement after the surgery in pediatric as well as adult patients. And then we also have developed and validated a performer which you can use for analyzing quality of life in temporomandibular joint ankylosis cases, because there was no performer specifically made for temporomandibular joint ankylosis cases. Now coming to how to reconstruct ramus condyle unit. There are various methods, but first, is it necessary to construct ramus condyle unit when your small gap is there? Most of the cases, when you are not creating extensive gaps, you can do without reconstructing or increasing the ramal height unit. But In the literature, these are the three methods: costochondral grafts or some other graft, autogenous graft, then distraction, and then alloplastic joint reconstruction. Earlier, this costochondral graft was considered gold standard because of its growth potential, biologic compatibility, and capacity to remodel into a neocondyle. But over a long-term follow-up, it has shown poor results. Most of the grafts resorb, re-ankylose, and sometimes I haven't ever seen overgrowth in my cases, but overgrowth has been reported. We did literature systematic review whether these costochondral grafts have any growth potential. But in the literature, if you want to study growth, at least 5-year follow-up is required. We could hardly see any prospective studies which have followed these patients for 5 years. So there is lack of scientific evidence for use of costochondral grafts in temporomandibular joint cases. For example, in this case, this is a very old case when I used to do costochondral grafts. This was treated with interpositional arthroplasty with costochondral graft fixed with 2 lag screws. Patient has got good mouth opening, but whether it is growing, when you follow these patients, still there is deviation. Deviation cannot be corrected. So still this patient has to undergo some orthognathic procedure. Same patient with deviation on mouth opening. So what's the advantage of putting costochondral graft? On the other hand, this is a small 1.5-year-old child. We operated with same technique, removed this fusion and placed just buccal pad of fat after placing, and then we followed. See, there is good mouth opening, patient is growing, there is no increase in deformity of the, so when you restore function, growth automatically will come. See, from 1.5 years to teenagers, there is still deviation, but I think he should catch up as he grows. Another girl, again 2 years, unilateral ankylosis, treated with same technique, followed up for maybe more than 12 years. She is symmetrical. There's no costochondral grafting, no autogenous graft, just release of fusion and packing of fat. That's it. You will hardly see cases treated at such young age not undergoing re-ankylosis. Almost all of the patients, when treated at such young age, developed re-ankylosis. But in our series, when we packeted fat, we haven't seen re-ankylosis in children as young as 1.5 to 2 years. See, same girl. This is the joint. She is opening well, pain-free movements, growing well. So some thoughts on alloplastic temporomandibular joint reconstruction. In the West, it has been used to treat end-stage TMJ disease, basically inflammatory pathologies. And it is successful there. Now 20-year follow-up is there, which shows long-term good success. And now, after looking at this success, some people have expanded the envelope to use it in pediatric and young patients. But there is unknown longevity after 20 years. And stock joints are not designed for ankylosis because jaws in ankylosis are grossly deformed and you cannot put stock joints there. You have to resort to, if you want to use alloplastic, then you have to resort to custom fitted joints. This is from literature. See, I had shown you this lateral fusion, normal, medially it is intact condyle, good functioning condyle. But what is being offered to this patient in literature is bilateral total alloplastic joint replacement. Because if you are replacing one joint, then there is thought that it will lead to some deformities or loading of the joint and it can lead to resorption. So some people are resorting to bilateral joint replacement in unilateral joint ankylosis. What I would have done, just remove this, 1 hour surgery, put fat, and everything is normal. And there is mushrooming of these shops which make PSIs now. Without considering any biomechanics, everyone is resorting to these PSIs, patient-specific implants. Look at this design. Some 4 or 5 screws, total joint reconstruction for hemimandibulectomy, and you want to give teeth also to this patient with the same implant. On the one side, this joint needs total cover, not exposed to any tissue. And intentionally, you are opening it to the oral cavity to replace teeth. And as suggested, this is the fate of these implants. This will lead to infection, and then you have to take it out. So you have to be very careful in choosing PSIs. And you have to be biomechanically very sound, very thoughtful, not like this, put 4 screws and then your joint is there. It will work for life. Now some thoughts on role of distraction. Distraction has got role in managing severe dentofacial deformity. For example, this patient, bilateral ankylosis, severe bird face deformity. We released his ankylosis and post-operatively he developed obstructive sleep apnea because he had open mouth, and then we had to resort to distraction to relieve him of his obstructive sleep apnea. Many years after surgery, you can do with distraction correction of dentofacial deformities, but distraction still has some problem. You have poor vector control. In this case, we were trying to distract some achieve vertical lengthening of our shortened ramus, and this upper stalk got fused. So vector control is a challenge. Patient developed re-ankylosis because of distraction. There is role of orthognathic surgery in managing these problems. Standard osteotomies you can do. You can take this maxilla up, rotate this mandible with VSSO, genoplasty. You can do virtual surgical planning. You can get your splints printed, and then standard orthognathic techniques like Lipot 1 osteotomy, VSSO, genoplasty, and you can achieve good results. So just summarize. So you have to completely release the fusion. Then you have to use fat to prevent heterotopic bone formation. Please put fat, whether you take it from buccal pad, abdomen, thigh, groin, take fat and put it. And then you have to do aggressive jaw physiotherapy. And then you have to individualize treatment plan for each patient, because patient is having some sleep apnea, then your treatment will be different. If there is minimal jaw deformity, your treatment will be different. If there is gross deformity, then their treatment will be different. and there is role of distraction and osteotomies in managing these facial deformities. Now I'll take stop here and then we will move to our cases. If any questions are there, we can take at this stage, or should we take it at the end?
We'll take it at the end, sir. We'll take it at the end, sir. Vidyarathan, sir.
Okay. Now, Ajoy, any inputs?
Yes, excellent presentation, and thank you very much. I'm waiting for the cases to come in, and maybe if I see if my thoughts are okay on this. Thank you very much.
We'll go for the cases, sir.
Okay. So is screen visible? You can see
No, sir.
case?
No, case cannot see.
Sir, I'll stop sharing the screen. Now you go for share screen and click on that PPT, sir.
I'll put share screen again.
Yes.
And
Select that presentation.
now, can you see?
Yes, sir.
Yes, sir. Come, sir.
Okay. Now this is a 10-year-old boy with chief complaint of reduced mouth opening since 2 years. He had trauma to his chin 2 years ago. You can see scar mark from the trauma here. And then this is during the trauma. Sagittal split fracture, bilaterally, lateral position getting stuck to the zygomatic arch, and over a period of 2 years, there is reduced mouth opening. These are his front and lateral profile pictures. You see very minimal changes because it is of recent onset. I'll show you now his mouth opening is 11 mm, minimal lateral excursions. These are his omitted OPG. This is his axial cuts. You see fusion there. These are right and left axial cuts. This is at coronal. You see there is fusion. Now, 10-year-old boy with bilateral ankylosis, post-traumatic origin. So, how will you manage now?
Can I?
Yes, sir. I
Yes.
can check, sir.
Yeah. So
We will go Mukul stepwise. First,
Okay.
in this case, I will suggest that we will go stepwise. We will
Okay,
study
sir.
how to give what are the anesthetic techniques, what are the anesthetic challenges. Then we will cover exposure, then cutting tools, how much gap to create. We will go stepwise. First is anesthesia. Rather than going straight forward to treatment, we will go stepwise. Now, choice of anesthesia and anesthetic challenges. Mukul?
you ask, okay. I thought, yeah, I know, of course, yeah, since mouth opening is not there, it is always an anesthetic challenge. And of course, today with the advent of fiber optic intubation, even pediatric fiber optic, that become the choice of anesthesia. So we railroad the tube on the fiber optic intubation, fiber optic bronchoscope, pass it when the patient is mildly sedated but awake. And SOS, of course, tracheostomy, but I don't think in the last 5 seconds we ever required the need of a tracheostomy for.
Yes. So there are advances in anesthesia techniques, and fiber optic intubation is gold standard. And there is no need for tracheostomy in managing such cases.
Yes, sir, agreed.
Ajoy, any inputs?
Yes, along with the fiber optic anesthetic techniques, I would also ask my anesthetic to give me a hypertensive anesthesia with tranexamic acid infusion and a bolus.
Yes, that will reduce bleeding. And then also what you said, second thing,
Hypertensive anesthesia with tranexamic,
yes,
tranexamic
yes.
acid, tranexamic infusion and bolus as well.
Yes. Then how to approach this joint now? Exposure,
So
your incisions.
can I go?
Yes, yes.
So you see, we have seen there's plethora of techniques which you can expose these joint, and mostly they are the preauricular ones. And preauricular could be combined with an Alcaid Bremley, that hockey stick incision. But of late, for last about so many years, we are approaching the TM joints, pediatric or adult, with a preauricular endoral approach. That is good enough for us.
And oral, that will hide the scar. You can easily
Yes,
hide the scar.
Yes.
It's hardly visible.
Yes.
But extended.
What we do is we take a standard preauricular endoral and divide the incision into two parts. One is above the zygomatic arch, and one is below the zygomatic arch. And below the zygomatic arch, at the trachea, we go at obliquely around at this that cartilage is there, and obliquely to the cartilage. If you go, you will enter into the neovascular plane, and which will lead you to the posterior surface of the condyle, or posterior surface of the ramus of the mandible, where it is, and that is the end of that dissection at that time. And then we move to the part which is superior to the zygomatic arch, find the fascia, and you will find some auriculotemporal vessels as well there, which you have to deal with it. And once the temporal fascia is found out, we join the tracheal incision and the incision, the exposure which is above the zygomatic arch, and you will ultimately fall into the arch, where you take a 45 degrees incision, expose the fat layer intervening, and then always your retractor or your periosteal elevator should be subperiosteal on the arch, and you move in anteriorly to the eminence. You will automatically fall into the capsule if it is there, or if it is not there, then onto the ankylotic joint.
Good, excellent. Any difference of opinion or different technique, Dr. OP, you will like to come in?
Sir, I have been practicing only that Popovich modification of Alcaid Bremley, which will anteriorly placed. And in my case, the scars are minimal. Even if mild scar is there, generally it is in the scalp, so it is hidden under the hairline. And the rest almost same, like sir said. I also use very commonly. I use that Morse number 9 mucoperiosteal elevator for blunt dissection once we reach to the zygomatic arch, and with blunt dissection only at 45 degree, we go anteriorly. So by the same incision, I can remove the ankylotic mass also, and if required, I can remove the coronoid also.
Yes, that is the advantage of extended incision. You can approach the coronoid and you can remove coronoid through the same incision.
You will be surprised with the endoral incision. You can do exactly the same thing.
Sir, I never tried. In fact, I'm comfortable with this incision because I have been doing that. And again, with the same incision, I can put temporalis also. That gives a very good exposure. So enormous amount of temporalis we can take, and we can just plug in whatever gap we have created. And generally, what I do, I suture that temporalis flap on the medial part of the ascending ramus, medial pterygoid, or whatever I get muscle there. I try to tug it so that makes a complete capsule in the articular fossa, medially covering the medial part of.
We will come to interpositional materials, Dr. OP.
So,
Yes,
yeah, even endural is perfect what I felt, but even I have a little pre-extension into the temporal region, just because I feel, I may be wrong totally, that the traction which we constantly do, especially to read the anterior part of the ankylosing mass, can give rise to some weakness of the temporal band. This is my feeling. So I have I have still not done it only with an endural, but giving it some kind of extension into the temporal.
No, Ajay is not saying only endural. He combined endural with preauricular. You need extended preauricular approach to expose the joint completely.
Mine is only preauricular with endural, but yes,
Yes.
everything is fine because it is in the hairline, so everything is fine. Yes.
Yeah.
So long as you can save the nerve.
Just not endural. Endural combined with.
So you have
preauricular.
temporal region, Ajay?
No.
He has no extension in the temporal region. That's what exactly I also thought. Yeah. So it ends at the superior part of the ear, right?
Yes.
Yes.
Sir, I had one doubt. If you don't extend to the temporal region, how you harvest the temporal lip?
So
that is a matter of discussion which we can come in when position is there.
I think.
Sure. Now we have exposed the joint. So we have to avoid injury to facial nerve branches. That is the main concern. And if you remain deep to deep fascia of the temporalis, then there are very minimal chances of injury to the branches of the facial nerve. Now, what cutting tools you will use to remove that gap?
I know Ajay's love for piezo, but I'm more used to the saw and the burr. I have tried piezo, of course, and yes, it is very good, but took a lot of time. So I feel I still to the saw or to the burr, 703 or whatever burr is required.
So we've actually published a paper about how to reduce the heterotropic bone formation, and a use of burr will cause a bone dust there. Whatever irrigation you do, or use of saw will also cause some bone dust, and these bone dust gets incorporated into the muscle all around, and that could be a nidus for the heterotropic bone formation. However, when we are doing with the piezoelectric, this bone dust is not there at all, and you have a proper you can actually control your cut. And the second thing is that it actually reduces the chance of bleeding from the medial tissues, because it doesn't really harm the soft tissues. And of late, for about last about 15 years, we have not used burr or saw in the temporomandibular joint surgery.
And do you remove piecemeal or large chunk?
Yes, anything is all right. We tend to do a piecemeal in a large ankylosis, especially the type 4 ones. But if it is an ankylosis which is on the screen, probably a single piece is all right. Yes, and you can also do a lateral arthroplasty should you want to do it.
Yes. So
that is again virtually we virtually plan the cuts and then go into that direction in case if you have a cutting guide. But I will come to that thoughts later on.
You are high tech. For everything you need cutting guides.
Basically, you know why? Because I think that a joint, any joint is an orthopedic joint, and if the orthopedic guys are totally into the cutting guides, then why should not we be?
Yes. Now we will come to.
But Ajay, sorry to interrupt. This is only you're talking of cutting guides only when you're doing an alloplastic replacement, right? Or even if you're just doing a gap arthroplasty.
So there is a paper for the lateral arthroplasty as well, in which they have used cutting guides, because whatever virtually you plan the removal of the lateral or a periarticular bone, that has to be simulated onto the patient. You can do it virtually, but then whether you have removed the kind of bone which is to be removed from the lateral side, if you have cutting guides, it will be wonderful. Yes, but not only for a gap arthroplasty. No, not really.
Yeah. Okay. Thank you.
Now, interpositional materials of choice. Would you do just gap arthroplasty? Would you like to reconstruct what you have cut?
Temporalis fascia, muscle or fat?
Temporalis fascia, just fascia or
I-
temporalis muscle pericranial flap?
Yes, yes. So depending on how much the gap is, normally I keep a centimeter. I don't know. This is one pertinent question which I feel we can differ about. 1 centimeter is what I feel has normally been. I have been practicing keeping a gap of 1 centimeter, other than of course alloplastic joints, and interpositioning either temporalis myofascial pericranial flap or only fascia also, or buccal fat pad also. But buccal fat pad, somehow there has been time when I found it a little insufficient. Maybe my technique is not as good as yours, Vidya, but I have somehow felt that the volume is a little lesser than what I would like it to be filled, which normally happens when you do a temporalis muscle or a fascia interposition. I would want the other people's view on this.
So if you ask me,
Yes.
I would rather do a. I mean, we do a buccal fat or an abdominal fat as well, but I don't want to do a temporalis muscle or a fascia interpositioning, simply because temporalis muscle has got that anterior temporal artery, deep temporal, and the middle temporal artery as its blood supply. But when you're rotating around the arch, what happens? There is a kinking of the vessels, right? So the distal most end of the temporalis, which is facing the lateral pterygoids or the medial tissues, will show will actually be devoid of blood supply, and that is a nidus for calcification to occur and later on heterotropic bone formation. So I don't want to do that. If you have to really do the temporalis interpositioning, then probably you need to probably create a bone gap there and then do it as I think it's given in one of the I think John Williams used to say that. But people have got good results with temporalis interpositioning, and there are innumerable papers. Some of them actually have taken the entire temporalis muscle and brought it down to the lower border where they have sutured that so that the entire medial surface is covered with the temporalis muscle. I don't do that. I normally would do a buccal pad or an abdominal fat. Our studies have shown that the abdominal fat has got less volumetric shrinkage over time, but both the fats are okay because the heterotropic bone formation does occur only for 9 months, and if it is not occurred during that 9 months, buccal pad of fat is also all right. The abdominal fat is also all right.
So, Dr. OP, any comments?
I have used only temporalis only. And what I do, I prefer
Temporalis, you're inferiorly based or anteriorly based? How do you take your temporalis?
at the 45-degree angle when we give that incision, we harvest the temporalis fascia that is thinner, so it is easy to handle that. Then on the temporal crest, I separate it anteriorly, so the temporalis attachment that is on coronoid process, it is completely attached, and from there I turn it out.
You pass it below the zygomatic arch and bring into the joint area.
Above the zygomatic arch.
To turn over. That
yes.
gives to some bulkiness there.
Sir,
Hollowing also it happens a little bit of the temporal.
Sir, generally I temporalis fascia only, so there is not much bulk, but yes.
The fascia is too thin to act as an interpositional material. You have to bring the bulk of muscle there.
But sir, it stays.
And based on blood supply, it has to be anteriorly based, not inferiorly based. And it should be brought below the zygomatic arch, passed below the zygomatic arch, and then brought into the joint area.
So that also we do. Sometimes below the zygomatic arch, sometimes above the zygomatic arch. And after that, I take that middle to the gap where we have created. I tug it there with sutures.
So now coming to this case, reconstruction.
One can I make a comment?
Yes.
An important thing in this, especially when you talked about the medially, the condyle remaining on the medial side, and when there's only a lateral lip of bone attached, the interposition material also can be the disc, the disc which lies on the medial side, which is displaced many times on the medial side. We pull it and make sure that it lies between the.
No, I do not agree with that. Let it lie there. It is covering good cover to medial part and it is attached to medial part. You should not displace it and bring it because your medial part then will be devoid of disc.
No, we are not dividing, we are not pulling it out. So when the part which is displaced medially, because the display, when there's a condylar fracture, the disc also displaces medially.
Yes.
So we get it back into its glenoid fossa, is what I'm saying as interposition, not pull it out.
So not whole of disc is medially displaced. Half of it is damaged. Only some portion of disc is there. I do not touch. I let it be there, and put some fat there.
Okay, we'll discuss because we have done this good amount of arthroscopic study where the disc gets displaced medially, especially in a high condylar fracture, and that needs to be pulled back and placed back in the glenoid fossa. Anyway, that could be a topic of discussion some other time.
So does this case require reconstruction of ramus condyle unit now?
No.
So it looks like that more than 2/3 of the condyle is actually functioning, and there is only a periarticular bone formation. If that can be removed, if there is 2/3 of the condyle, they should function fine. But if it is anything less than 2/3, as said by he et al., probably osteoarthrectomy would be required. But this is 2/3 remaining. Good. Looks like there is a disc there as well. Should be a lateral arthroplasty, should work fine bilaterally.
Also, his age, I think, is 10.
10 years.
Yeah, so we should have some growth potential for him. I mean, you don't not reconstruct it as of now.
So everyone agrees that just lateral arthroplasty, put some fat there.
So I somehow don't believe in lateral arthroplasties, but yes, that is
for this case.
Yes, this is a mild case, so can do, because this is just a excessive bone formation periarticular. So juxta-articular, I would say.
Yes. So this was done through standard approach. Then that bone was removed, fat was placed. This is post-op mouth opening of around 35 mm. This is post-op CBCT. You see, without this condyle, just removal of this lateral bone. And he has got beautiful functional joints. No need for reconstruction of any alloplastic material or any harvesting of costochondral grafts. This is pre and this is post. Now, can we move to second case?
Yes, sir. Yes, sir. Can go ahead, sir.
So this is second case, 19-year-old female, which is a case of re-ankylosis. She has been operated once at the age of 8 years, and she has got reduced mouth opening since 11 years. And she had some infection in the joint area at the age of 1.5 to 2 years approximately. So it is a long-standing region where there is, and patient has also got history of snoring and daytime sleepiness. Sleep apnea, she is suffering for the last 3 years. These are her profile pictures, lateral profile and front profile. You see there's obvious bird face deformity. These are the scar marks of previous surgery. So obviously she has got retrognathic, micrognathic, microgenia. There's prominent antigonial notching. Distances are reduced. This is her occlusion. Mouth opening is nil, no excursion, no protrusion. This is her OPG, which shows dentation and extensive fusion of the joints. This is, what could be this structure?
This elastic.
Yes, plastic was placed in the previous surgery and just there is fusion. It has got displaced laterally and there is fusion on the medial side. There is elongation of the coronoids, and this is the elastic. There is extensive fusion in sagittal cuts. These are axial showing. Then there is a decreased airway space. We didn't go for sleep study because it was obvious, straightforward case suffering from sleep apnea and reduced airway space. So what are your thoughts now on managing, how to manage this case now?
So we draw up a problem list here. And the most pressing problem is an obstructive sleep apnea.
Absolutely.
And the second is the TM joint, which is not functioning. So, our studies, which is published as well, has shown that if you do only mouth opening in these patients by means of osteoarthrectomy, the mandible will further go back and the hyoid will also go back. This will worsen her obstructive sleep apnea, and a moderate sleep apnea can turn into a difficult ones and a severe sleep apnea.
Yes.
So what is required is, I think, the mandible corpus length of the mandible and the ramus has to be increased, so that along when it moves anteriorly, when you're increasing it by distraction osteogenesis, it will take the muscles along with it, so that the nasopharyngeal and the oropharyngeal airway will increase, which will be beneficial to this patient. Now, once you have done the distraction osteogenesis in this patient and taken the entire mandible forwards to, let's say, edge to edge, or maybe more than edge to edge, because there is obviously some relapse which does happen in distraction. And then what you do at that point, if you do a minimal arthroplasty or a gap arthroplasty, the mandible will again go back. So at this point, when you're doing an osteoarthrectomy for this patient, you will need a patient-specific total joint replacement in this, or have to do a ramus condyle unit reconstruction in this patient by any means, by alloplastic or by autogenous. But since she's 19 years old, I think a total joint replacement is the answer. So a distraction first, osteoarthrectomy, total joint replacement, abdominal fat packing, extensive physiotherapy, follow-up of the patient for heterotropic bone formation. That is my plan.
Dr. Opi? Yes, Mukul.
So I don't know. I will. If the patient has to go in for an alloplastic implant and a custom-made alloplastic implant, then I can avoid distraction. I can make an alloplastic implant, placing the mandible in a more inferior and anterior position than what it is now. So I create a gap and give a joint with a little longer, a custom-made joint, which has the foot plate much longer and anterior, by which it places especially in a bilateral joint, it places the mandible more anterior. So if one were to do alloplastic joint replacement, then I will possibly not have the distraction at all. I'll place the mandible anteriorly in the same situation. This is what I feel. Otherwise, conventionally, I'll do distraction followed by a gap arthroplasty or keep space, but may not be an alloplastic joint replacement. But if it is alloplastic, I'll do it at one stage and not distraction then.
Ajay, do you agree that we can treat this patient one stage?
See, there is now overwhelming evidence that you can do it. But believe me, we have tried doing all these kinds of counterclockwise rotations, and to bring the mandible forward, especially the ankylosed mandible, and to dissect the medial tissues and pull it anteriorly is some job. And what happens is that all the virtual planning goes into tizzy if the mandible doesn't come forward that much after doing the osteoarthrectomy and the medial dissections. What happens then? Then your patient specific does not fit. And this will, the stock joint is out of question in this case. So, and when you're bringing the mandible forward, then you will also have to do a concomitant orthognathic surgery to drop the maxilla down and do a bone graft there as well. Now, all these procedure increases the chance of PJI, that is periprosthetic joint infection in these patients. I would probably want to go in for a distraction first. In case if everything is hunky-dory, then probably a single stage can be done, or it can be managed in 2 stages as well. As I say that, what you do is that you do osteoarthrectomy and put in a large silastic block, but that silastic block has to be wired to the temporal bone so that that soft tissue expands there. And once that has happened, at a later date, you can go in for a patient-specific implant and create do a ramus condyle reconstruction as well as anterior positioning of the mandible. As I say, there is no one way to bell a cat.
How will you treat Dr. OP?
Sir, I will first go for distraction, mandible and maxilla together like Molinar's technique. And after that, after the distraction is complete, I will go for little overcorrection. And after the distraction is complete, then we will go for typical ankylosis treatment.
Maxillary distraction. Maxillary distraction, I think I will not think of maxillary distraction in this case.
Sir, it is not maxillary distraction, but we will combine both jaw and
Intermaxillary fixation and distract the mandible is what he's talking about.
Molinar.
Yeah. So both get distracted, even the mandible comes down.
Occlusion, and along with the mandible, the maxilla will rotate with little bit anterior distraction also, mild distraction. But mandible will distract completely.
Yeah, definitely mandibular distraction is required, but maxillary distraction, Ajay, do you agree? Does she require maxillary distraction?
I would probably want to look at her cephalometric assessments and clinical assessments because I think the oropharyngeal airway looks all right. It is the nasopharyngeal is the problem. And she doesn't really require a cant correction. So simultaneous maxillomandibular fixation and distraction probably may not be required. But as I say, what works best with you, that's all right. Yes.
So that is my take, sir. And whatever you said, that also can be done, but I may not be doing that.
So this is what we did for this. We did distraction first before the release. This is pre-release distraction with Synthes multivector distraction device extraoral. What will be your choice? Will you go for any intraoral or custom or external distraction? Ajoy, your choice?
Yes, you see, with ankylosis patient, the intraoral distractor placement becomes slightly difficult and to create a osteotomy there. So we also use the similar distractors and maybe sometimes striker distractors as well. Striker has got an advantage that you really don't have to drill the holes for putting the pins because they are self-drilling pins. So they are very good and very fast in and out quickly. Extraoral 3D distractors, yes.
Yes, this is Synthes extraoral TC 3D. So distraction was done for this. So we overcorrected it. There is cross pipe. And after consolidation, waiting for 6 months. How much you will wait before going for your osteoarthrectomy?
5 to 7 months. Yeah, 6 months is good.
So we were following the evidence, and which suggested that 3 days for a millimeter, and we have burnt our fingers with that. And my colleague Rahul Yadav actually does keep it for 6 months, and he also gives vitamin D and calcium along with it. So, and it has worked very fine with him.
So any chances of this non-union, or you don't get good callus, there's no calcification, because patient starts opening at this where you are distracting.
You're right. It does happen.
How to overcome that?
So when you have distracted, when the distraction is complete, and in case you're using a 3D distractor, put the patient into some kind of bite which the patient has, and then probably I think you have also used these brackets to do the intramaxillary fixation.
Yes, because there's tendency for open bite. Patient starts developing open bite, and then you have to control that vector and open bite, and you require some fixation so that movements are less and there are good region rate you get.
Dr. Mukul wants to add something.
No, I said basically you're trying to get some kind of bite. It's callus molding basically, post after your distraction, so that you have some amount of intermaxillary fixation you require. Even elastics are fine.
Yeah.
I wanted to say something. Like here we got frostbite, no? If we could have given one lipo to an osteotomy also, then this frostbite would not have come. That was my case.
Okay.
It was not distraction. It was just along with our distraction of mandible, the maxilla will also
Right.
adapt it.
But intentionally we have done overcorrection, because when we are doing gap arthroplasty, then it is still go back. So this is after distraction removal, then patient was taken for ankylosis release. With same technique, you release the ankylosis, put fat there. We achieved around 30 millimeter of opening. And these are the gaps which have been created. Patient developed some anterior open bite after gap release. But in my experience, within 3-4 months, that anterior open bite settles and patient readapts to its new environment. This is after distraction and after release of the ankylosis. Patient has got good pain-free mouth opening.
So no reconstruction of the joint?
No reconstruction of the joint.
May I ask you something?
Yes.
Sir, how did you cut the bone in this case? What armamentariums you use?
I use standard straight handpiece 702, 703 bar. When cutting, when you are going medially, then you slow it down. You take your large acrylic trimmer like bar, and then you have on the medial side, you are always careful and you are protecting it with your periosteal elevator, that you are not dipping in.
Thank you, sir.
I find piezo very slow. I use it very rarely when I have to use it around the nerve. That's the only indication, or for sinus lifts, nothing else.
Works very well for orthognathic also, sir.
Yes, when
Ankylosis, I somehow find the bone much more tougher. I know.
So we were the first ones to profess the piezoelectric for the TM joint surgeries, and believe me, the BS1 long piezo saw with the ones which we use as an Action machine, it doesn't take really much time. And with the new Stryker aspirators, it's absolutely like burr only. And the other thing is, you don't really have to have that bone dust all around your tissues. You see, if you go to the orthopedic operation theaters, you will see that whenever they use this large burr or the cutting drills for the removal of the bone, what they do is that they have ultrasonic irrigation devices, which they want to remove the entire bone dust which has gone all around the total hip replacements or total knee replacements. And in the hip, they also put in a lot of abdominal fat.
Now we move to case 3. This case is treated by Ajoy and given by Ajoy. I will like that. Ajoy,
Yeah.
you should go ahead with this case.
Oh, is it? Okay.
Yes.
So you see, this is a 19-year-old male with unilateral condylar injuries about 10 years back, and he has about 10 millimeters of mouth opening. If you see his face, you say that there is a fullness on the right side, there is flatness on the left side, there is chin deviation to the right side, there is deviated nasal bridge towards the left side, and you have basically this is a TMJ ankylosis with a orthognathic problem. Yeah, is short mandibular base, retrogenia, short posterior facial height, retrognathic mandible, and a convex profile. His occlusion seems to be absolutely fine with angles class 1. And if you look at the radiographs, you will see that he has got an osteoarthrotic chunk there. His intra-articular reduced spaces, antigonial notch is increased on the right side, and that shows that this is quite a long-standing ankylosis and reduced jaw function. And if you look at his coronal sections, you will see that there is a periarticular bone formation, and there is also, as what we say, is some kind of medial condyle which is there. You can if you look at the sagittal sections, you will see that whatever gap you're looking at is actually also filled with some kind of bony tissues, as well as the osteolytic areas. Now, these osteolytic areas, you can say that this is a disc and this will function well. It can, yes, but what is really happening in the heterotropic bone formation here is that the calcification started, but it is really not being picked up by the CT scans here. And if you see the axial sections, you will see that there's an extensive ankylosis going right up to the medial side, and there is a very little medial condyle which is functioning there. These are orthognathic dimensions for this patient because he also requires some kind of facial correction. We will not go into much detail, but the assessment is that he has retrognathic mandible, he has retrognathic chin, he has short posterior facial height, he has a steep mandibular plane, he has short mandibular base, and he has a steep occlusal plane. If you look at his PA cephalogram, you will see that there is an occlusal cant of 5.5 degrees. There is a chin deviation of 15 degrees. There is a mandible base discrepancy of 18.9 millimeters. That is GA, Menton, and AG. So how do we proceed? And maybe someone can fill in as to what would be the problem list, what is the planning and sequencing, and what are the expected outcomes. I'm asking the panelists.
Yeah,
Maybe
so I think problem list is 2. One is the mouth opening, of course, and secondly is the facial deformity. So you want to have a good mouth opening for the boy, and you want to correct his facial deformity at the same time. So planning would be possibly an aeroplastic joint on the right side, the ankylosed side, followed by an orthognathic surgery, a genioplasty, or an orthomorphic correction, any of them, for the deformity of the chin and the deviation and the flatness on the left side is what I feel.
Yeah. Oh, Dr. Om Prakash.
Sir, I would like to go for distraction, and after that ankylosis release and soft tissue mock-up with some abdominal fat or something.
His occlusion seems to be absolutely angles class 1. So what distraction are we looking? Maxillomandibular distraction, you want to say?
Mandibular distraction only, sir. The same way, like I said, I will go for port 1 osteotomy along with our vectors as planned for this side. 1 second, sir. This looks quite good. Can we go back to the shape?
He's got a right TM joint ankylosis.
So PA says, so only one side, only right side distraction we will go, and automatically the skin will also get shifted to left side, along with the same occlusion, what occlusion we have got. And after distraction, we will see there will be a marked defect, soft tissue defect will be, flattening of the cheek will be there. That should be corrected with some soft tissue correction.
Yeah, but we will have to keep the patient for distraction for about 6 months with the distractors on. So that is probably one of the disadvantages, I guess.
Yes, that is.
Ajay, I would like to go with staged approach. I feel there is just lateral fusion. I'll open up the joint, release the ankylosis, wait for at least 1 year, going further for second stage. Second stage will be standard orthognathic procedures. Left foot 1 down fracture, sagittal split osteotomy plus genioplasty.
So may I ask everybody, is that when you do the lateral arthroplasty, do you really force open the mouth, or do you just do a chin with a thumb so that let's see how the mouth opens? So we do that quite a bit. And in case if the mouth doesn't open more than 25 to 30, we know that there is a problem on the medial side as well.
And role of coronoidectomy, where you will do coronoidectomy and where you will
so
not do.
Coronoidectomy on the ipsilateral side is a must for most of the patients.
Sir, I accept your concept that medially we try to preserve the joint when joint is good. But what I practice, the ankylotic part, I completely make it completely clear, almost 1 centimeter or more than 1 centimeter. And after that, if it is not opening, then we go for coronoidectomy. Then also, if it is not opening, then contralateral coronoidectomy. And sometimes other side also, the ankylosis has to be released, because we get the cases which are delayed cases. So generally, both sides it is used. One side good ankylotic mass, one side maybe fibrotic, maybe ankylotic also, like that.
This is unilateral ankylosis. There's no need of opening the other joint. Even in delayed cases, other side, if it is normal, there are lateral excursions, I will never open it. Sir, it's a normal functional joint. There's no need to touch the other joint, which is normal. It has not ankylosed, even when all the chances of ankylosis are there. When you are opening it, how it can re-ankylose, or it will lead to not reduce mouth opening.
Vidya sir, just on what Ajay asked just now, the same thing. Do you check the mouth opening when you keep that entire medial stump there to see if it's opening, closing the mouth, or how?
I forcefully open the mouth with Hester's jaw opener intraoperatively. And I am not worried, because when I am putting fat, even if mouth opening is not there on table, but after 6 months, it keeps on improving with time.
Okay, thank you, sir.
So coming back to the case, if we can go to the problem list. We've seen that we've discussed that panelists have opinion about the lateral arthroplasty and a second stage orthognathic correction. Somebody has one of the panelists has an opinion about the distraction osteogenesis, maxillomandibular simultaneous for CAN correction, and then going for an osteoarthrectomy, and then probably a fat packing is a gold standard these days, and you can't do an ankylosis without a fat packing, either from the buccal fat or the abdominal fat, abdominal area. And thirdly, about the lateral arthroplasty, what really happening is the ankylosis is not a normal bone formation which is happening. It is the heterotropic calcification or heterotropic ossification. Now, in the literature, they have been used simultaneously, one place or the other. Now, it is actually a distinct biological process, where there is a collagenous proteins and other cellular components are trying to form the bone. Now, once the pathological process has started, I don't want to leave any pathological process there. I don't want to. I am going to treat this joint exactly as I'm going to treat a hip joint or a knee joint. So if the pathological process has started, no doubt the fat will reduce that process. But what about if there is a medial bone formation in about 5 years or 6 years time, then what happens? Yeah. So I want to remove all the bone formations which is there, and then give him a normal joint. And alloplastic joints are almost most let's say similar to the natural joints which are available, apart from the lateral excursions and anterior translations. You can do a single stage orthognathic surgery, or you can do a 2-stage orthognathic surgery in this patient.
Agreed. I will do the same, Ajay. Total joint.
So let's see how this was treated. Yeah. This is a computer-assisted planning for this patient, and you can see that there is absolutely a total facial scoliosis in this patient. Yeah. Next. Okay, so this is if you see the even there is a functioning condyle which we can say functioning, but this will definitely have some kind of issues. And I do not know if the radiolucent zone which I'm looking at in the medial condyle is not calcifying or not ossifying or not heterotropic bone formation which is happening. But again, I can say that you can treat this with lateral arthroplasty, or you can treat it with an extensive approach as it was done in this case. Now the area where you want to do the osteoarthrectomy. You see, we've published a paper about strategies to reduce the re-ankylosis in patients in British Journal of Max-Fac Surgery. And what we do is that the skull base thickness, morphology, and proximity to all these are measured, and the inferior cut is at the narrowest part if you look at the coronal section. Now, the idea behind doing that is that when a large area of temporal space, temporal bone which you have cut is opposing almost a similar amount of cross-sectional area of the mandibular stump, then there are more chances that there is a heterotropic bone formation, and jumping of the osteocytes can happen on a re-ankylosis. But if you cut it much below, where the ramus is thinnest, and it is almost about at 1 centimeter, 1.5 centimeters below the ankylotic mass, then the less amount of the bone is opposing a large area of cut bone of the temporal areas. So you have less chance of osteogenic jumping in these areas, or less chance of heterotropic bone formation if you have packed it with the fat. So that is the idea behind doing a 1 centimeter, 1.5 centimeters osteoarthrectomy in these patients. However, if you were to use a total joint replacement, the fossa always requires a 1.5 centimeters preparation. Yeah. So what we do is that you want to do a patient-specific implant for this. So now this is a patient, you do a virtual planning and you do a virtual surgery. And if you see the first green, which is labeled as cutting jig, it shows a upper cut and the lower cut. And these screws are exactly like the screws where the future fossa is going to be fixed. So you fix the cutting guide and cut make the cut, superior cut and the inferior osteoarthrectomy cut, and then you remove this osteoarthrectomy mass and then put in the fossa exactly at the same place where your screws of the cutting jigs were placed. Now this is why you want to do, because you want to transfer your virtual planning onto the patient, and in case if there is any error in this, your patient-specific the mandibular component will not fit, and your orthognathic surgeries are not going to be exactly similar to as what you are doing. Yeah. So if you see that you have superimposed both the things, and then you've made the cut. So now the question comes: if you are rotating this maxillomandibular complex, then do you need to do a contralateral sagittal split osteotomy or not? So the evidence has shown that you can do away with the contralateral sagittal split in case if it is less than 7 degrees movement, and that too only in the condylar area. So beauty of virtual planning is that you can plan the entire movements, keeping the point of rotation. If you see the second picture, point of rotation at the condyle, and you rotate it about 7 degrees, or in this case, it was only 5.5 degrees, and you rotate it, and you can fabricate, design your patient-specific cutting jigs, implants, and fabricate them using either 3D printed technology or a CNC 6-axis technology, which is far better than a 3D printed, which I feel as well. So this circles which you are looking at in the previous slides are the areas of rotation, and this we do it on a medical imaging software, Mimics 24 suite. Now you have to rotate this, the mandible, and you have to make the patient-specific implants, but you need to correct the cant as well. So this is a orthognathic surgery cutting jig for a leaf 1 osteotomy and a cant correction. And I'm not changing the occlusion at all. I'm only rotating the maxillomandibular complex as you would do with the distraction, but that would require about 6 months time for the patient to have a good mouth opening and a profile as well. So what you do is that you plan your cutting jigs, yeah, and you plan your screw holes exactly at the same point where the movement of the maxilla would happen, because you don't get second chance to make holes in the maxilla, because as you know, all of us know that it is very thin bone, and if you go in and out and make a lot of holes in it, you will probably have no areas to fix the plates then. So these cutting jigs are made, and the plates are planned exactly on those holes where your future maxilla is going to fit. So if you see the second slide, the holes are exactly at the points where the future implant is going to be placed. So what we do is that you rotate the maxilla and place and design the plates, and on those plates you design the cutting jigs so that the holes are actually superimposed on each other, and then you don't have to make more holes in this, yeah, and your exact transfer of the virtual planning goes onto the table, yeah, and then you fabricate your patient specific Lefort 1 fixation device. Yeah, once that is done, once the fixation device is planned, then you plan your mandibular component, and once the mandibular component is planned according to what you can see in this virtual planning, then all the holes are mapped, yeah, exactly as we will know exactly 8 millimeters, 10 millimeters, and all the holes are mapped, and this mapping is available with you on table in the operation theater, and you can use exactly the same millimeters of length of the screws which can be placed. And then again, make sure this virtual planning, beauty of virtual planning is that you make sure that you're not injuring the inferior dental nerve which is passing in that area. Okay, and then again, obviously, even if you do a 5.5 degrees cant correction, the genium is still on the right side. So you do a genioplasty as well. And then again, if the mandible is not really come anteriorly because we are just rotating it, so you do a double barrel genioplasty. And all of us, we know that how difficult it is to control the fragments in double barrel genioplasty. But if you do it with a patient-specific cutting guide and patient-specific implant, it becomes a very, very easy procedure. And whatever defect you have, you can fill it with the bone, which you have already taken out from the osteoarthrectomy areas. Okay. Yeah. So I think this is just a 3D simulation, but this doesn't really give a good picture anyhow ever. Okay. Yeah.
So my only excellent, perfect planning, and I think that is exactly what is required for this patient. My only thing is you do the genoplasty at the same time. You don't have the fear of a pocket formation up to the area where the foot plate is.
Yes, yes, you are right. Many people want to do a genoplasty at a later date, but we do it at a single sitting. Always.
Because that is one fear which, there could be a pocket going from the genoplasty cut to the foot plate, allowing oral microorganisms to go into. We want to be
as you know, our penchant for smaller incisions, we don't give more incisions even for a genoplasty, which is almost in the canine to canine level actually. So there is a lot of tissues which is available, but theoretically you have a point that there is always a chance of the tissues making a pocket going up to the joint and causing a periprosthetic joint infection. So this is how the model looks like, yeah. And you see that, I mean, for total joint replacement, there is a strict aseptic protocol which is there, and pre-operative antibiotics, and dipping the implants in the vancomycin solution for almost an hour before during the surgery, yeah. And these are the smaller incisions which we do. This is a pre-auricular endural approach. We try to suture the cartilage to the ear, because we don't want the ear canal, which is infected, causing some infection into the implant area. Okay, cutting jig, which is fixed. What we do is that you expose the pre-auricular as well as the retromandibular approach, which you take just parallel to the sternocleidomastoid, go deep to the platysma, and then you go deeper into the medial tissues and expose the posterior belly of digastric, because that is the base of my dissection. Because in case if there is a torrential bleeding which happens, you just have to cut the digastric, and the terminal branches of the external carotid arteries are there as well. Yeah, so these incisions, and then this is a piecemeal technique, which Vidya, you were mentioning. You take out the bone with the piecemeal technique, and you create a nice, good gap with a light, good medial tissues. You always palpate the medial tissues, and you can see the holes there. And these are the holes where the future fossa is going to be fixed. Yeah. You open the mouth of this patient and achieve about 30 to 40 millimeters of mouth opening in this patient. And you can do a contralateral sagittal split osteotomy as well, yeah, and then a Lifford 1 osteotomy. But in this case, it wasn't done. Now you opened it up, okay. You fix. This is a patient cutting guides which have been fixed on the maxilla. There is a disadvantage, because you really have to expose a lot of maxilla in this when you're doing this technique. It is you can do with a single cutting guide from left to right, or you can do with two cutting guides separately. Single cutting guides have advantage that nothing can go wrong, but in two cutting guides, maybe a millimeter or so can go wrong in these patients. Yeah, you down fracture the maxilla, you put the patient specific, and this is plug and play. Believe me, no splint required, nothing. All you have done is you have drilled the holes in your cutting guide, and exactly at those holes your implant, which is going to be fixed, and your cant is going to be corrected. Once you correct the cant, you see that there is more than 5 to 7 millimeters of bone gap in the right side. So you graft that area by taking the advantage of whatever osteoarthrectomy you have done in these areas. Yeah. Okay, then you go back to your, once you have done that, you go back to your joint, fix those joints. Lot of problem here. You see, every time you go intraoral and extraoral, you need to, everybody in the operating theater has to scrub these, has to descrub, and then again come in, and you need to put in you need to put in those iodine transparent tapes all around. You know, it takes some time and some kind of training in terms of the team to really reduce or minimize the chances of periprosthetic joint infection in this. Yeah. So you fix in the fossa, and you fix in the mandibular implant from the retromandibular areas, and take out the lot of abdominal fat. I like abdominal fat because the globules are thick and are very resistant to volumetric shrinkage. And you fill this entire area with fat. Yeah. Okay. Then you go into the anterior genioplasty. You fix and see this. This is a cutting guide, and you know that the superior cut and the inferior cut, everything is there, and the holes you just drill there. I don't normally put screws in all the holes, but I drill all the holes and put screws in only 2 or 3. Yeah, because in case if you are removing the screw and then again putting a screw, it might just strip off. So once you do the double barrel genioplasty, very simple technique in this, if you're using a patient-specific cutting guide and a patient-specific implant, and then fill that entire area. In case if there is some kind of dimpling or some kind of concavity which is occurring in the labiomental fold with the bone graft, again putting into the bone mill and putting it there and closing these areas. Yeah. So this is how he looks in the follow-up. You can argue that there is still some kind of fullness, but obviously if you compare him with the pre-operative, he looks much fine, much better, and in the follow-up he has a good mouth opening. If you can see the next slide. Yeah, see, but the deviation will always remain because the lateral pterygoid anthesis is not really happening. And in case if that happens, then it'll be fine. But otherwise, he's okay. So you see there is some kind of lateral movement as well, but not great because the lateral pterygoid is not attached. Occlusion remains fine in the postoperative period. However, you can see the mild opening is there, but this is going to subside in no time. I mean, this is probably actually in the follow-up as well. And if you see his preoperative and a follow-up Grumman's analysis, scaphalometric analysis, you see that his facial asymmetry has been corrected. This is a new thing which we do is a quality control study as to whatever we have planned and whatever we have executed. We superimpose that exactly on the same planes and see if our planning and the post-operative execution has been same. And in case if we hit about 90%, we are fine, and we know that our quality control has been maintained. And we have been able to exactly transfer our virtual planning onto the patient by means of a patient-specific joints and implants. So for this, what happens is my take-home message for the people, for the audience who are tuned into this, is that computer-assisted planning and patient-specific implants allow to get an accurate pre-planned results. These are challenging cases, especially when patient expects all treatment in one go. Staging is an option, but rarely agreed by patient. Orthodontics was not possible in this case. Technology and established surgical practices work in tandem for the best results.
So thank you, Ajay. Excellent results. But staging is an option, but rarely agreed by patient. I will not agree with this statement. Patient always agreed with staged approach. And what about cost? High-tech technology, everything comes with cost. And goal of treatment is cost-effective treatment.
If we go into cost and what is the standard and what is the standard of care, then obviously this is expensive. But thanks to our Prime Minister, who has given a lot of options to these patients, and they do get a lot of fundings from the government and the other sources and the corporate social fundings. I've been doing this total joint replacement since 2014. And not many have actually spent for the total joint replacement from their pockets. Yeah, not many. But yes, it is an expensive treatment. And as it is becoming popular, the metal 3D printing costs are coming down every day.
How many rupees? Can you tell us the number?
So if we go into macroeconomics, you see, microeconomics, you see, you cannot compare the rupees with the two surgeries and the mental harassments of coming to the hospital.
That's okay. I want a number.
So it would cost anything from 100,000 to 150,000.
With all cutting jigs and reprinted plates.
Everything.
Okay, sir.
We have overshot very much on time.
Yeah, sir.
So, any questions? Is there any time for questions?
Sir, we have already overshooted the time, sir.
Yes.
So we can go for the concluding remarks. What of time?
So, concluding remarks.
Dr. Vidya did a great job.
From you, sir, from all of you. All four.
I'll say you have to customize.
Yeah.
It's not a standard treatment for every patient. You have to look at the clinical features, everything taking into account. It is your duty to give a custom treatment for that particular patient. And second message I want to give is put fat. Whenever you are opening joint, put fat to prevent ankylosis. It really helps.
Yes. I think customize a treatment plan is the most important part.
Yes.
Om Prakash, sir. Concluding remarks.
I agree. we have to see in which facility you are working, and according to that only we have to go ahead. And one take home message is there, always put hat.
Ajay sir.
Yes, my message is that temporomandibular joint is any other joint in the body. Treat it like an orthopedic joint. And if you look at the orthopedicians, and if you take away the total joint replacements from the orthopedic practice, they will be with no work.
Thank you. Thank you, sir. I thank the moderator of today, Dr. Vidyaratan sir, and Dr. Ajay Chaudhary sir, Dr. Mukul Pajay sir, and Dr. Om Prakash sir for your exhaustive discussion. And though it is TMJ ankylosis, we went for orthognathic surgery, distraction, obstructive sleep apnea, and everything. We have covered everything, including patient asymmetries. So with nice photographs, nice radiographs, and exhaustive discussion with clear explanation, so that the questions are also, whatever the questions were asked, were already answered in your discussions, and with good treatment options and nice management, sir. And I thank all the participants of the webinar. There are around 123 participants to a maximum of 139 so far. This is the highest in our IBOMS session so far. This is third by me and total by 8 by IBOMS. This is the highest. And I thank all the IBOMS members, my friends, colleagues, students for spending your valuable time on today, Wednesday, to encourage the profession, to improve the knowledge and take the profession to the next level. And I thank the A1 Logics for their technical support and technical assistance extending the time. And I hope we will meet again with a new team within one and a half month. And thank you again. Thank you. Take care.